welcome you to the show today. It's Hunter Lundy for the people. And the special guest today is Dr. Patrick Hayes. Dr. Hayes is a clinical and administrative psychiatrist who practices in Southwest Louisiana and in Houston, Texas. He has an incredible, impressive vitae. He's the medical director of these two private practice operations serving thousands of patients. But he served time in the military, and he's a native of Massachusetts, but he studied psychology at the University of Tulsa in Oklahoma, received his master's degree in desert ecology at Sul Ross State University in Alpine, Texas, before commissioning into the Army for medical school at the University of Texas Health Science Center, and continued on. He completed his psychiatry internship and residency as at Triple Army Medical Center in Honolulu, Hawaii. He was honored to serve in Baghdad, Iraq as the chief of behavioral health department of the 28th Combat Support Hospital and received the Bronze Star for his service in a combat zone during Operation Iraq Freedom. He's received numerous other awards and recognitions, but I don't want to take up all our time today talking about what an impressive curriculum vitae or resume that you have, and the service that you've been not only to the people of Louisiana and Southeast Texas, but to the United States. So welcome to the show, Dr. Hayes. And I want to go through, I've kind of touched on your education and your background, but I know from personal experience what you've done in evaluating people and helping people that have had injuries such as post-concussion syndrome and post-traumatic stress disorder, and how you've specialized in, I would call, addiction treatment, people that have addictions, how to get free. And you've done, and it's only been, and we've never really met in person like we are today, but I've seen your work. We've used your services, and you're just one of a kind. So thanks for being on the show today. I think we're focusing on brain injuries, and so many people don't realize what traumatic brain injury is, post-traumatic stress disorder, post-concussion syndrome, etc. But I want you to tell the audience, first of all, about your veteran experience and your first responder work.
Yes, sir. Well, first of all, thank you for inviting me, and thank you for your kind words. I appreciate that. Yeah, so I was a wanderer. So Massachusetts, Oklahoma, far west Texas, Mexican border of Texas, Louisiana, Middle East. There are a lot of overlaps in behavioral health. So I'll just kind of throw that out there early. Many of these things are not going to be discrete little single conditions. There's going to be a lot of overlap of bleeding into one another. And my experience is kind of like that as well. So, I mean, I started in petroleum engineering. That's what got me from New England to Tulsa. Decided I like people more than engineering. So I ended up with a psychology degree. Then I did a sojourn up to far west Texas and picked up a master's in biology with most of a second master's in criminal justice. So desert ecology, plus also the criminal justice side of stuff. And then I'm actually an Army veteran as well. So I commissioned in the United States Army for medical school. And I did the HPSP scholarship program, where you go to a civilian medical school, and during breaks, during the summers, then you go do Army stuff, Army training. And upon graduation, then you give the Army your time for additional training, internship, and residency, and then you're back afterward. So I got to do a total of 12 years in the military as part of that program. Invaluable experience. I wouldn't trade any of it. It's some of the best training, I think, in the world, and certainly the best experience in the world. So having been able to do that, having seen boots on the ground from the very tip of the spear, the infantry guys, the light armor guys out there that are being exposed to hostile fire, the signature wounds of the Afghanistan and Iraq conflicts are mental health and traumatic brain injury. And often the traumatic brain injury, as we discuss it in that context, is mild traumatic brain injury, the post-concussional syndrome. So all of those consolidate on a deck of experience where I'm pretty comfortable diving in with somebody that may have difficulty sleeping, difficulty reacculturating to home, difficulty with headaches, where there's an overlap between neurological conditions and psychological conditions. Fundamentally, a physician, a psychiatric physician, is an interventionalist. Our job is not simply to describe what's going on, but to help people out of the predicament they find themselves in.
Well, you know, I had two great uncles that served in World War II. One was in the infantry and Marines, and one of them was in the European campaign in the infantry. And I think to listen to my great aunts describe that they both suffered from some type of post-traumatic stress disorder. And I think it was at a time frame when the medical community really didn't know. And or if they did, they weren't applying their therapy like you're doing with so many veterans today. And then in Vietnam, I had friends that went to Vietnam, and they came back with similar. You know, if you can help us and help our veterans in this brief time that we have together, to describe what symptoms that you regularly see that might indicate that they need the care of someone like you, or you in particular, because of your experience.
Yes, sir. And one of the effective metaphors of considering these conditions is they're overloads. So if you have an emotional overload, something gets in your psyche, something affects you in a way that you aren't expecting, or there's a component to the narrative that is somehow noxious or morally repugnant. And these are difficult situations you mentioned earlier that first responders find themselves in, soldiers, airmen, sailors find themselves in, Marines find themselves in. Whether or not they caused it, there can still be difficult hiccups to these exposures. So that can overwhelm one's personality or psyche or persona. And then on the blast side, it's a circuit of mechanical energy. So there's too much physics, there's too much physical energy from the universe coming into the CNS. And they're not mutually exclusive. In that, I mean, that you can't always separate out, okay, this is an emotional injury, this is a mechanical injury. They often overlap with one another. So if you're in the suck, as they would call it, the infantry guys, the ground pounders, and something bad happens, it can often be bad in several different ways. You can see collateral damage, you can see unit damage, you can have suffered some personal damage, be that physical or brain or emotional. So there's often a lot, as I mentioned earlier, there's a lot of overlap in these conditions.
So tell the audience the difference of the work that you perform versus that of a neuropsychologist or or just someone who's involved in clinical psychology versus a psychiatrist. And I'm sure you work closely with those who do more day-to-day therapeutic work than evaluation and treatment, if that makes sense, or medical treatment work.
Yes, sir. And these would all fall under the general overarching umbrella is medicine. And then within that, you have the overarching umbrella of behavioral health medicine. And within that, you can subspecialize into different disciplines. You've got psychiatrists, psychologists, neuropsychologists, and you can go on down the line in levels of refinement. But in general, these are using modern medicine, using modern tools, modern techniques to help alleviate human suffering. First, to describe it, figure out what's going on, to develop an effective metaphor that you can characterize an illness in a way that you can craft a treatment plan from that. So a psychiatrist is a physician, and fundamentally we're going to work on the body, on the somatic systems, on how to optimize the likelihood of fill in the blank. So if somebody can't sleep, we want to optimize the likelihood of sleep. If they're irritable, we want to minimize the likelihood that they're reactive, that they're explosive. If they are re-experiencing troubles from something they saw or something that happened to them, we want to minimize the likelihood that those really bother them. If they're having difficulty with concentration, we want to enhance the likelihood that they can focus, that they can attend to the tasks that they want to do. Once you get more to the psychologist, those guys come up through the School of Arts, Arts and Letters, and they're typically, the terminal degree is a doctor of philosophy or a doctor of psychology. And a psychologist will often determine origins, help facilitate determining where the origins of an insult are, help craft these treatment metaphors, and then they will typically engage a patient in interpersonal therapy of some sort to help the person gather understanding, to put themselves in a place where they can grow from the traumatic exposure and not be crippled from it. And there's some caveats to that. The DOD, New Mexico, Louisiana, there's a few other states now where psychologists can take additional training and become prescribers. But in general, once a psychologist becomes a prescribing psychologist or a medical psychologist, they behave more like a physician or a physician's assistant or a nurse practitioner. But at the end of it all, be it through talk therapy, be it through testing, be it through prescriptions, through other interventional techniques like transcranial magnetic stimulation, other electroconvulsive therapy in refractory cases. These are ways to try to assist a patient in getting back onto the trajectory where they had been.
You mentioned physician assistants and nurse practitioners. Do you see many psychiatrists that have those assisting them in their medical practice, or is that something that's really for different discipline other than psychiatry?
Oh no, there are vast more what are collectively referred to as mid-level providers in certainly Louisiana and Texas. I'm also still licensed in Hawaii, so I'm familiar with that landscape. But there just aren't enough physicians in the country, period. There certainly aren't enough behavioral health providers in the country. There aren't enough psychiatrists in the country. That's where the school of medical psychology essentially comes from, so that patients don't have to wait 6 months, 9 months to get in with a psychiatric provider. And I'm actually on staff at, I believe I precept or serve as a preceptor for 5 nurse practitioner schools. We recently had a young man come through a physician's assistant school, and I'm on staff as an adjunct at one of the medical schools, helping to train the next cadre, the next generation of providers. But in all the operations just in Louisiana, I believe I have 14 or 15 nurse practitioners presently helping me, simply because there aren't enough physicians to cover the demand.
And that's interesting to know, and I'm going to say that the average citizen doesn't know that, and this is very educational. And of course, probably most professionals in my profession has been the law over the last 40 years, but I have experienced the psychiatric analysis that you've done and others have done that is really beneficial to the healthcare of people. I just wasn't aware how much, if you would equate a psychologist to like a practitioner or physician assistant or not, but that helps me understand. I'm sure it helps the audience understand too. Particularly, have you been involved in, I know we talked a little bit about post-concussion syndrome and post-traumatic stress disorder, and I'm going to ask you again to distinguish the two if you can, and then I'm going to ask you about chronic traumatic encephalopathy, and have you had occasion to treat people? And I'm thinking the CTE has to do with some of the athletic injuries. Maybe I have it wrong, but I mean, I want you to clarify that for the audience, if you would.
Yes, sir. So the difference between PTSD and mild traumatic brain injury, they can often sound more discrete than in reality they are. So the post-concussional syndrome, it has been long described in the literature. One of the manuscripts, a couple of colleagues and I published in residency, we went back and did a literature search on PTSD, on some of the constellations that have been described. We're talking about Civil War, we're talking about World War I, Sargent syndrome, irritable heart of the soldier, shell shock. These are terms that people are familiar with. And it has made its way into popular media. I mean, we're all familiar with, anybody can name a movie where either PTSD or traumatic brain injury are described. But both can have sleep problems. Both can have hyperarousal. In PTSD, there can be irritability. In post-concussional syndrome, there can be irritability. PTSD through an affective pathway, a mood pathway, there can be difficulty with concentration, with sustaining attention. And it physiologically makes sense. If you're in fight or flight, it becomes difficult to attend to small stimuli, minutia. The brain is preparing itself for big things. And then if you've had a mechanical head injury, it becomes difficult to concentrate. The theory is that the neurons aren't necessarily connecting well enough or communicating well enough with one another. So as we go through the list, there are several features that are common to both. Where it starts to split a little bit, there are several that are more unique to the mechanical head injury that you don't necessarily see in most cases of PTSD. That's where we get into dizziness, nausea, sensitivity to bright lights, sensitivity to loud sounds, not easy startle. You can have easy startle more so in PTSD, less so in traumatic brain injury, but just where loud sounds bother the individual, where you can have lots of headaches, more so with the post-concussional syndrome than PTSD. But if we distill it all back, if you look at PTSD, you've got a person that's sleeping poorly, they're irritable, they're irascible, they're hypervigilant, they're hyper-aroused. Those people are more likely to sense their own internal signals and more likely to assign a negative value to them. So even in those where you may not have any component of mechanical head injury, they were far from a blast, or it was an incident that didn't involve an explosion or a fall or a concussive head injury, you can still have some overlap of those. But as you start putting these symptoms as they're reported by a patient, or these signs that you can observe, these findings on testing or in laboratory studies, as you start putting these together, you can describe them effectively because the treatments have some overlap, but there is some difference as well.
Have you treated any NFL athletes or college or high school athletes that have had traumatic head injury from repeated concussion type syndrome?
Yes, sir. I have worked with athletes. Probably my most represented cohort in that group with bona fide chronic traumatic encephalopathy, which is it's a clinical diagnosis, and it can be bolstered with fairly normal labs and some imaging studies. But on the whole, we're not going to do a brain biopsy to establish that diagnosis. But boxers, I have worked a lot with mixed martial art fighters, boxers, individuals both at the amateur and professional level. Several of them have had quite significant cognitive decline, findings that are entirely consistent with CTE.
Right. Yeah. And I know this is probably a controversial question, but have you seen any soccer players in recent years? Because it's such a growing sport in America and in high school, and it affects all our families, including mine with my grandchildren, who've had repeated contact with the ball in their head that's making some type of physiological change.
And I'm with you on that one. I was a soccer player throughout high school. Not a very good one. It's back in the day where the balls weren't the hand-sewn soft ones. They were these heavy stones that would just bang into you because you didn't know how to get your body in position. I have not personally had soccer players, but it is something that in working with traumatic brain injury, actually had a TBI clinic for the Army up at Jones Community Hospital. The screening those sports, because patients may not think to tell you that. They may not think, okay, I'm not a boxer, I'm not an MMA fighter, I'm not a race car driver that's had multiple crashes. They may not tell you about soccer history. So it's something that we'll, the other clinicians and I have built into our screening questions just to make sure.
All right. The audience probably wants to understand as well. Most people understand what a grand mal seizure is or a seizure is. But there's a lot of discussion about TIAs today. Could you tell the audience, what a TIA is and what a symptom of a TIA would be that a family member or a friend or a coworker could observe?
Yes, sir. And a lot of these are similar, but orders of magnitude or the scale of the event. So generalized anxiety disorder, a panic attack, hypervigilance of PTSD, That is excess electrical energy of the brain that's contained within the brain's usual operating systems. A seizure is where you have an electrical storm within the brain that exceeds that. So it generalizes. Essentially, it's crossing pathways in neural loops that it should not. When we start talking about TIAs or stroke, a TIA is almost like a light stroke. So something has happened with vascular supply being critical for oxygenation of brain tissue. Something has either occluded it, or there's a spasm in one of the vasculature apparatuses. Something has blocked it off momentarily, and you'll have stroke-like signs or symptoms, but it doesn't go to a full stroke, which it's a common term. But typically what we mean by that is something has been damaged. It can be an occlusive stroke where something blocks one of the vascular supplies and brain tissue dies without oxygen, or it can be hemorrhagic. Most people are familiar with an aneurysm. It's just an outpouching of a blood vessel, but they become weak. So it's almost like blowing into a cellophane bag. Where it bubbles out, it's much weaker than the rest of the cellophane bag. And then because of the hydrostatic pressure of the system, they can pop, and that's a hemorrhagic stroke where it bleeds into the brain tissue. And then that blood itself can either damage tissue, or it can create a source for irritation within the brain.
Yeah. And over the years, through education processes, the public has become more aware, and I can use my own life as an experience. When I was a child between the 8th and 9th grade, I was visiting my grandmother in Mississippi with my cousins, and I got thrown off of a horse, and I hit my head, and it cut my, and had to go to a local GP and get stitches. But I was probably out for 20 minutes, 25 minutes, because my older brother and sister drugged me up on my mamaw's porch and waited till my parents got home. But, I came back, all the doctor told my parents was don't let him go to sleep for a while. That was the point of concern. And this is many years ago. If I told you, you'd know how old I am, and I'm old. But anyway, so I started 9th grade football. A week or so later. And, no one knows or knew at that time the dangers of having now that was an acute, because it cut my head, and I had an invasive, I had stitches and so forth, but it was a severe concussion. And I think that, God protected me. I broke my arm the first scrimmage that kept me out of 9th grade football. But I think had I continued to play with the head injury, it would have been sincere. Today, I know that medicine is so much more developed, and doctors are educating their patients better. But am I crazy, or would I have been at a serious risk if I'd have continued, playing contact football after a concussion like that was acute? I just feel like I was protected by the breaking of the arm. Can you elaborate on such a hypothetical as that, which is not really a hypothetical?
No, these are risk probabilities. So if you've had an excess of mechanical energy to the brain, then it is more susceptible to additional insult. And one of the metaphors I'll talk with patients with, in my office up front, I've got a lot of plants growing. And if you have live plants, not all of them are going to do well. So if one of them gets stomped on, or if I'm out of town for work and it doesn't get watered, it's not going to be as robust as the one next to it. So head injuries are much like that. If you have a significant enough head injury to knock you out for 20 minutes, you have done something physical, something of actual real world energy to the brain that has insulted it, and essentially shut it down for a minute. The brain is trying to do something adaptive, keep you from running around, keep you from causing additional problems, puts you down on the ground. Now, if you have another insult of that magnitude or worse in rapid succession, and sometimes even less magnitude, you can have what's called a second hit, where individuals can die from that. So that's one of the concerns. That's why modern sports medicine does not put kids right back on the field the next day. Why you typically have to wait 10 days, 2 weeks, 30 days before getting back out there. And then people are more cautious with that. But the CTE guys, and what ends up happening with the boxers' brains, with, as you inquired, potentially the soccer players' brains, certainly professional football, college level football, you're continuing to get mechanical insult to those little growing plants, to those neurons. And then over time, bad things are happening to them, whether a neuron dies, and then neurons are fussy little buggers. So if one of the pieces of it that communicates to another neuron gets torn a little bit or gets sheared, it's likely to involute and die. Now we have hundreds of millions of them, and we have billions, if not trillions, of interconnections. So if you lose one, if you lose 50, if you lose 1,000, typically all is not lost. But if you continue to lose 1,000 every Wednesday, every Friday, every Saturday for a 15-year, even an amateur career, somebody that goes through Pee Wee football, high school football, college football, there can be cumulative effects to that. And then the brain is also less resilient to additional stressors later, be that a car crash, be that exposure to alcohol, be that a surgical mishap. There are other things that can happen that brain that had this cumulative, iterative dose of mechanical energy applied to it, it's just not as robust as one that didn't.
I want to move in just a second to the subject of addictions. But before I do that, is there any particular pattern that you've seen? Because I know that you've treated patients from all over the United States. They come to Southwest Louisiana to see you because you do have the experience and the expertise that many other psychiatrists do not have, because of your veteran experience as a veteran, because of your work for the Department of Defense, because of your treatment of first responders. And I can go on and on, but they come from all over. And so we feel fortunate to have you in Southwest Louisiana right now. But have you seen a pattern over the years of distinction between the psychological or psychiatric injuries of wars? In other words, is the Vietnam veteran different from the Iraqi veteran? Is he different from the Afghan veteran? Are they different from what's going on today, maybe in Ukraine, in which we don't have many, if any, combat veterans involved, but we've got people around explosions. We got them around concussions. I mean, today, soon we'll be talking about what's going on in Israel, how it affects Americans. Have you seen any pattern that you can know? Maybe there is none, but I'm asking out of curiosity.
Yes, sir. And the conditions that we're describing, they're found within the context of an individual's, not only their persona, their personality, their psyche, but also within their society and within their culture. So there can be vast differences in how an individual internalizes fill in the blank, be that difficulty sleeping because of their combat exposure, intrusive thoughts about something they saw or did or was done to them. Many individuals will view that as their own weakness or their own moral failing. And that can cross, to the spirit of your question, that can cross generations as well.
Right.
So I recently, I do some work for the VA through one of their contractors on the admin side, just IMEs, just establishing disability, effectively, compensation and pension exams. And I recently did a CMP exam on a World War II veteran, a Korean War veteran who was in his 90s. Very different from a recently returned Middle Eastern veteran. So somebody that's in their 70s, 80s, 90s, this stuff was weakness. This stuff was a deficit of their character. This stuff was, even if they could get past that, it was not to be talked about.
Right.
You were to come home, you were an American hero, and then you were supposed to go do your thing and be fine. And even in modern military culture, military medicine, it's really fantastic. And the VA does a fantastic job. These are big systems, and there's always going to be examples of difficulty with fill in the blank, with access, with prescriptions. But on the whole, These are generative, effective systems that are trying to do the right thing. From having worked in the military for a long time, from having continued to see DoD individuals and family members, continuing to see veterans, both clinically and administratively, the groups are trying to do the right thing. But within that, there are differences in how the person internalizes what their experience is, how they access those services, what they feel the meanings of those things are. And even as the systems will allow individuals more leeway into that, we're trying to get people into services, we're trying to optimize their likelihood of doing well. There are still generational issues where people just don't want to, they don't feel okay with it.
Yeah. Well, I think you pretty well summarized the distinctions and how cultures affect some of our veterans and how they're treated. And I know because I came through, and I was, when I registered, Vietnam was still going on, and of course they stopped the draft in 1973. But there were a lot of people a lot of young men and women came back from Vietnam that felt like they were a man or woman without a country by the way they were treated. And that changed over time. And I think the respect that we have for our veterans today is back to where it was after World War II and World War I. But I mean, we saw the Korean War bring in a different persona, and then the Vietnam War. But I think today, what we've seen happen, and even whether we like it or not, the way Afghan ended, we've seen our veterans treated differently and respected after Iraq and Afghan. But I was curious as to what your statements would be. I don't want to run out of time without us talking about addictions, because I know that there'll be a lot of mothers listening. Before I move to that subject, do you treat patients with dementia or Alzheimer's, or is that totally the neurologists and neurosurgeons that do that? You treat them as well?
Yes, sir. And the distinction between a neurologist and a psychiatrist, we're both boarded by the American Board of Psychiatry and Neurology. They are parallel tracks. You can be board certified as a neurologist or board certified as a psychiatrist. And then there are subspecialty boards therein. Neurologists in general work on the structure of the brain and the function as it derives from that. And it largely, and this is a gross oversimplification, but largely they are on the macro scale. Yeah. So a neurologist is often going to work with seizures or with the location of a lesion in the brain, whereas psychiatry also has to do with the function of the brain, but it's more on the micro scale. It's more on the meta. So how the brain is thinking, how the emotions are, how the mood is, versus a gross electrical storm that needs suppression with anti-epileptic medications. Now, there's quite a bit of overlap in that. And having been in the military, having deployed, having run a traumatic brain injury clinic, that pushes me and with me, my team, in a more neurological direction. And then I also work with hundreds of individuals with intellectual disability across the state. Most of the southern half of the state, my team and I have some hand in a lot of the group homes, the folks that are out living with family members. Those guys have a lot of medical conditions. They have a lot of epilepsy. They have a lot of refractory seizure conditions. So I have worked a lot with that. And then as individuals go through the lifespan and become older, mild cognitive impairment, Parkinson's disease, Alzheimer's disease, frontotemporal dementias, those all become something that someone's going to walk in your office with those. So you have to figure out how to assist in diagnosing that, how to optimize their likelihood of living the life that they want to live with their family.
So you have the occasion to look at a lot of MRIs, CAT scans, brain scans, PET scans. Do you have the occasion to review those when you're treating patients, just like a neurologist or a neurosurgeon would?
Yes, sir. We typically have access to those. Now, I will occasionally look at my own imaging. In general, the radiologist, the neuroradiologist, the MRI neuroradiologist, as those guys subspecialize, as they become more refined in the services that they are providing, I will defer to them. But there are unique cases where the clinical constellation doesn't really match what we're seeing, and either I will or the team and I will go back and review direct images.
Before we run out of time, I do want to talk about the addiction problem that we've seen in recent years, and I know you have a subspecialty certified in addiction medicine. And what have you seen in the recent decade as far as addictions? I know that you were involved in the opioid, not only in the problem with it, probably in the litigation of it too. You were probably asked to give your opinions on how opioids were being used for medical treatment. But why don't you elaborate on that subject matter a little bit for us?
So going all the way back, I can remember in medical school, I can remember the first year lecture on the pseudo addiction of opioids, and that if it's you see addictive behavior, then it's actually uncontrolled pain. That was during the whole social movement of pain as the fifth vital sign, where additional treatment is what's indicated. And then, as we discussed earlier, as a military guy, I was in medical school 2000 to 2004. So, of course, 9/11 was 2001. So I caught essentially that entire experience. And then body armor is fantastic. So where the signature wounds are emotional and TBI, numerous thousands of individuals are also suffering from peripheral injuries, amputations, penetrating wounds of the legs, the arms. So lots of pain medications being used. And what clinical reality showed over that generation, clinical generation, training generation, was that in fact, overprescribing opioids is not safe. Overprescribing opioids creates problems. You're trading one issue for another. Yeah. So fairly early, the data treatment program, Drug Abuse Treatment Act of 2000, has been around for a long time, but it's a way of managing opioid use disorder. And in 2011 or 12, I did the training on that, was certified. I began providing opioid use disorder services in approximately 2013. But no, these are crippling illnesses for people. And we now know that it crosses not only the behavioral sphere of the individuals, but also the physiological sphere, also their social sphere, and then there's cultural impact as well. Back to the idea that the pseudo addiction, treat more, pain is the fifth vital sign. And Southwest Louisiana has unfortunately been at the epicenter of some of those difficulties. We are, of course, along I-10. We're in between major metropolitan areas. We've got Houston to the west. We've got New Orleans to the east. We've got casinos. We've got major rail. We've got water access. So it's not surprising that some of the vice problems, substance use, human trafficking, will fall in our lap. So I actually had to, with Imperial Calcasieu, I'm their medical director. It's the state mental health agency. We had to do a joint broadcast with the coroner, because for a period, Louisiana had the highest fentanyl overdose rate in the country, and Calcasieu Parish had the highest rate in Louisiana. So even though we're a small metro here, even though it can feel rural at times, we have been racked by the fentanyl epidemic, which, as I travel across the country for work, it's everywhere now. But fentanyl being a contaminant, either inadvertently in illicit drugs or purposefully put in there to enhance the impact of them, it's highly dangerous, and we're losing thousands of individuals every year.
I heard a statistic yesterday that we had 108,000 people die in America last year due to fentanyl, and you've described it. Of course, last month's Hunter Lundy for the People podcast was on human trafficking. This month it's on the brain condition, and that's why we chose you as a psychiatrist and for the very subject matters that you've been discussing. And so I think every mother, every parent should be listening to this podcast today about symptoms to look for their children and teenagers, young adults. And yes, there's a a problem with the hiding and lacing of other drugs with fentanyl that's killing so many people. And it's impacted my friends and family members, one in particular that I can think of, and other ones that we know, and you probably know thousands because of who you are and who you treat. But I mean, if there's anything, before we run out of time, if there's anything you can tell the audience about specifically parents for their teenage children as to what they should look for, what they should observe, how they should pay attention to their children with respect to these problems with these drugs, especially fentanyl.
Yes, sir. And I have for many years done root cause analyses of unexpected negative outcomes. That can be a demise. Of course, we weren't expecting that. That can be a significant suicide attempt. That can be a significant medication problem. Anything that happens where it doesn't go the way you'd planned, and it can lead to, death, loss of life, or loss of limbs, eyesight, major negative outcomes. And in doing those with the state system, where we currently have probably 3,750 patients or so across the 5 parishes in Southwest Louisiana, we used to have one of those every year or so, maybe 2 a year. Within the last 2.5 years, really post-COVID and during the fentanyl upsurge, we're seeing that number sometimes more every month. So it's out there. That's one of the key messages that people should know. This is not distant. This is not just in LA. This is not just in Miami, not just in Portland. This is in our neighborhoods. This is next door. And then the key to look for is out of character, fill in the blank, out of character, anything. So I'm the proud dad of 3 boys. They're very successful guys. My youngest is now 19. He's in college. So they've essentially gotten into their adulthoods. And I bring that up because kids can be unpredictable and moody and, quite frankly, pains in the butt from 12 to 18 under the best of circumstances anyways. But if you start seeing seasonality to their changes, if you start seeing social withdrawal, or if you start seeing out of character over energy, if you start seeing massive shifts in their social groups, if you start seeing out of character behavior in your partner, in your spouse, in your colleague at the office, it's worth the Battle Buddy program has now been surpassed, but it comes to mind where fundamentally the Battle Buddy program was just jump in and ask. If it looks like there's a problem there, maybe you won't be helpful, but maybe you will be, just by jumping in and asking and being available for it. That reduces stigma. It pulls it out of that Korean War, World War II mentality of I shouldn't have this, there's something wrong with me, I'm just going to drink or snort this or smoke this. It opens up the grounds for dialogue. And then I just got done a visit right before this podcast where it's an individual that doesn't like how they feel. They don't like the illness. They don't like the sensation of the symptoms that they're having. And they also don't like taking the medications. So my job in that setting is just to be available, just to listen, just to explain what treatment options are out there so that person can think about it. And that person ultimately may tell me no in this setting. They may tell me no 2, 3, 4, 5 times down the road, but it sits in there and they think about it. Okay, this dude's listening to me. These aren't toxic things. We aren't trading one problem for another. What I've been doing or having or experiencing is under the umbrella of the normal human condition. And there are things we can do that will push it in the direction of helping it out. So the same thing with if you got a kid that's struggling, that's falling into some substance use stuff, don't want to promise you that as soon as we identify that, we're going to be able to cure it. But you're going to do 14 days, 28 days inpatient psych or rehab, and it's going to be gone. No, but it didn't take 14 or 28 days to get there. And the ground to help that move forward, to grow through it, to develop different coping skills, it has to start somewhere. So noticing it and opening up a dialogue are probably the 2 most critical things.
Well, I want to tell the audience today that we've been so fortunate and blessed to have you, Dr. Patrick Hayes, as a guest, someone of your reputation, not just in the state of Louisiana and Texas, but nationwide. And you've been so informative and educational today that I think every parent needs to listen. Yes, we talked about fentanyl, but I mean, we don't have time to talk about alcohol, but I know that's a problem as well that parents have to pay attention to. But thank you for your time. Thank you for your information. And if we can ever have you back on the program, we want you back on the program, because 45 minutes is just not enough. Thank you so much.
Yes, sir. I appreciate the invite. Thank you for your kind words.
Thank you.
Thank you.